Welcome to another Rob Kall Future Health radio show, where we're going to be talking about mind, body, heart, spirit, health, consciousness, transpersonal psychology, biofeedback, neurofeedback, and tonight my first guest is Kall Swingle. Now, the way this show works is we do part of it live on the radio, and then it continues afterwards on the podcast. So if you really like what you're hearing on the radio, you can check the website at futurehealth.org, and there will be a link in the diary for the night's show where you can go to download the podcast for the whole radio show. That's futurehealth.org. Future Health is the sponsor of the show. It's a great place to get lots of articles and information about all the areas that we cover. We have some good news for Future Health. It was just approved by Google News to be a news site with them, which means that our articles will be picked up and reach a lot more people. So tonight I have as a guest an old friend and colleague, Paul Swingle. Dr. Paul Swingle was a full professor at Ottawa University and a lecturer at Harvard Medical School. He's now in private practice in Vancouver, Canada, where the Olympics are taking place very soon. That ought to change your life a little bit, Paul. And he's got an enormous amount of experience and creativity in the world of biofeedback, neurotherapy, the brain. And he's got one of the biggest neurotherapy practices in the world, seeing 12,000 visits a year. So welcome to the show, Paul.
Thank you. Good to be here.
And you've always got a lot of exciting new things happening. What are some of the exciting things you're working with right now?
Well, the major thing that we're doing is looking at developing stimuli for brain driving. So let me just explain that for a minute. The form of neurotherapy that most folks are familiar with is biofeedback for the brain, brainwave biofeedback. That's a volitional procedure, as you know, in which for kids we set it up. So basically they're playing a video game with their brain. You know, when the brain's doing what we want it to do, rocket ships move across the screen, dolphins jump out of water, and so forth. Brain driving is a little different. Brain driving is what we used to refer to as classical conditioning, in which we set it up so that when the brain is doing something, we measure that and then deliver a stimulus to change that condition. So, for example, if there's too much slow activity in the brain, and when that becomes too high, then we turn on a set of lights or a sound, or with adults, microamperage stimulation of acupuncture points to drive that waveform back down into more normal range. It's very, very effective for people who can't participate in the usual form of feedback. Folks like very severe autistic kids, people who have had serious brain injuries, serious developmental lags, and so forth. These are folks who can't participate in volitional forms of neurofeedback, where brain driving is extraordinarily effective for this. So we've been doing a lot of work with the Biofeedback Foundation of Europe in terms of developing software programs so that folks around the world can learn how to use my procedures. And that's very exciting.
What does it involve, brain driving? How does it work?
Well, let's say we have a very severe autistic child who basically is not able to respond to neurofeedback in its usual way. We would set it up so that let's say we're trying to drive down the excessive slow frequency that you often find in autism. What I mean by that is waveforms that might be more appropriate for sleep and daydreaming and so forth are found in...
So you're saying an autistic child you will see while he or she is awake has brainwave activity that you would see in a normal person who's sleeping.
In the wrong place, that's correct. What that means is that area of the brain is hypoactive and not functioning at efficient levels.
Okay.
So what we would do is we would put an electrode over that area in the brain and measure that waveform. And when that waveform started to increase in strength, then we would turn on lights, for example, shining in the child's eyes so that it will drive that slow frequency down. And as soon as it gets into normal range, the lights cut off. Now, as you know, I've spent a lot of my research career working on harmonics that impact the brain as well. These are sounds that have very specific effects on very specific waveforms. Those sounds would start as well if there was too much of that slow frequency. Now we have other ones that will encourage particular waveforms, so they kind of grab what we call in the industry entrainment, so that when that sound comes on, it makes that waveform stronger. So we're using a non-volitional procedure here in which the child does not have to be attentive to a screen or any feedback or anything of that nature. Once we do this to the brain, the child becomes more and more aware and responsive, and then we gradually shift them over into regular brainwave biofeedback. So it's a very efficient process.
Okay, this is Rob Kall with Future Health Radio, WNJC 1360 AM. I'm speaking with Dr. Paul Swingle of Vancouver, Canada, British Columbia, and he's talking about a new or a unique way, an approach that he takes to helping autistic children with ADD, ADHD, that combines brain stimulation and neurobiofeedback, or brain biofeedback. Now, what kind of success do you have with this, Paul?
Huge. We're really pleased with this. Now, we do this in other cases. For example, if we run into a situation in which a client doesn't seem to be progressing, then we will do brain driving as a more aggressive kind of treatment to nudge the brain into more normal functional ranges. A good example of that is a client who has been exposed to a severe trauma, emotional trauma. Very often what that does, as you know, I presented papers on this at your conferences, is that it blunts a particular waveform, the alpha waveform. The alpha brain waves from 8 to 12 cycles a second, and when you close your eyes, there should be a nice jump in the strength of that waveform. If you've been exposed to a very severe emotional trauma and haven't dealt with it properly, that wave is blunted, so close your eyes, you don't see any increase.
Okay, now let's talk about this in practical terms. The alpha brainwave is the one that's associated with the calm, quiet mind states where you're able to let go and relax, right?
Also visualization.
Okay, but it sounds to me like if this is based on trauma blocking alpha, what it means is people who have had trauma can't really relax and maybe can't visualize as well, right?
Absolutely, and that's exactly what happens. If you relax some of these individuals, they go into a full-blown emotional abreaction. So when the brain
abreaction, put that into plain English, please.
Yeah, an emotional reaction. They become very upset. They start to cry. They have an overwhelmed by emotion associated with the trauma they've experienced. In other words, it's an emotional flashback.
So where the average person might just sit down, close their eyes, and become quiet and relaxed, someone who's had a trauma or maybe post-traumatic stress disorder, I assume that this ties in with PTSD as well.
Absolutely.
When they sit down, it can actually set off a stress response rather than what we might ordinarily expect.
That's right. That's the paradoxical impact of relaxation with a traumatized client. I mean, we've known this for years in the peripheral biofeedback work, in which if you quiet somebody, sometimes individual gets very distressed by that. And, the old metaphor, you see ripples in a calm pond. So when you calm things, that's when all that emotion starts to bubble up to the surface. So you can actually think of this in the sense of being stressed and vigilant is protecting you against flashbacks. That's kind of the metaphor. So the brain is protecting itself against all of this negative emotionality by blunting the alpha response. Now, where I discovered that, by the way, is when I was at Harvard Medical School treating combat veterans with post-traumatic stress disorder at McLean Hospital. They don't have an alpha response. It's negative. And again, that makes infinitely good sense if you think about it. It's the brain protecting itself against these horrible emotional flashbacks. Now, what we do for clients in which we're doing regular neurotherapy and they're not progressing because of the impact of the trauma, that's when we use the brain drivers. Remember, it's non-volitional, so that we're driving that waveform up and then triggering the emotional release associated with the trauma. It's the most efficient psychotherapy on the planet because it engages.
Oh, wait! Did that? You just throw in something new. You drive the brain to a certain point, and then you trigger the emotional release.
That's right.
Explain that, because you kind of took a leap there.
Yes, once the alpha comes up and the brain is no longer blocking the alpha response, and no longer putting the lid on the trauma release, the emotions associated with the trauma. Once you release that, the person's going to have an emotional reaction to that. And when they do, they dream more about it. It's on the front burner. Sometimes they have overwhelming feelings and memories of, the traumatic event. Sometimes these are way, way, way back in their history. And that's why I say it's the most efficient psychotherapy on the planet. Individuals engage the body's own psychotherapeutic mechanism for dealing with this stuff in dream state and on the front burner, and we have a chat with them. They might have a session or two with a psychologist here, and then we get started with the regular neurofeedback.
Let me just take a couple steps back and go over this with you. So what you're saying is people who have had emotional trauma or PTSD, their alpha brain waves, the ones associated with a quiet mind and relaxation, don't show up as readily when they close their eyes as normal people have. And
it can actually go negative. It really is blunted.
Okay, and actually, what I'm getting from this is is really a kind of a defensive system that prevents them from re-experiencing the trauma and the emotions, right?
Bingo.
And so
or at least, what
you do is you drive them to produce more alpha so that once they let go a little bit, the flashback comes, and you want that to happen.
That's right. You want the emotionality to release, and that's exactly what happens.
And you're doing it in a controlled situation in a clinic. So
that's correct.
Now, so I would guess then that if somebody messes around with teaching somebody with PTSD to relax without keeping this consideration in mind, just sends them home with a relaxation tape, that cause some problems, eh?
You bet. And this is one of the major problems we have with all of the franchises popping up claiming to do neurotherapy. Bored perfume salesmen decide they want to help people, so they get themselves an EEG machine and become neurotherapists because it's not a protected title or a protected area. We get a lot of casualties from that.
Now, there is certification in credentialing in neurofeedback. You can become board certified through BCIA in neurofeedback. What do you think about that?
Oh, I think that's extremely good first step. Unfortunately, there's no legal teeth in it. Those of us who get... I'm sorry.
that's a way for consumers to have some certainty that the person's going to be competent, though. If they're board certified through BCIA, that's bcia.org.
That's correct.
Right?
Now, I have a whole section in my book, as you know, on how to select a neurotherapist.
Oh, well, you have a book? You have a book, Paul? What's the title of your book?
Gee, I thought you'd never ask.
I'm getting there.
It's Biofeedback for the Brain, and it's published by Rutgers University Press.
Okay. Biofeedback for the Brain, and I assume that's available on Amazon? And
you bet.
Okay. Good. And while we're at it, why don't you give us your website address? I'll say it. You gave it to me a little earlier. It's swingleandassociates.com. SWINGLEANDASSOCIATES.com. Swingleandassociates.com.
That's correct.
Yeah. Now, I know you're going to be giving some webinars online for professionals and the public.
Yes, we're giving webinars under the auspices of Biofeedback Foundation of Europe.
Okay.
And the first inaugural one is coming up next week, January 20th, and that would be 1 p.m. Eastern Time. Folks can check it out at bfe.org.
Okay.
And this one is addressed to, again, biofeedback for the brain, in which we look at my rapid assessment procedure and brain driving. My rapid assessment procedure, again, as you know, because I did a lot of workshops at your conferences with about this, is a procedure in which it only takes about 6.5 minutes of recording time, and we don't ask people why they've come to see us. We tell them why they're sitting there, because the brain tells us absolutely everything, and we have full databases for this procedure. I find it much more effective than doing the large brain assessments, because you're giving instant feedback to the person.
Now,
and it's rather like cognitive.
When you say large brain assessments, are you talking about QEEG, quantitative?
Yeah, the full Qs.
Yeah, okay.
We do those too. If somebody comes in with epilepsy, traumatic brain injury, whatever, we go immediately to the full Q, the full brain assessment. But generally speaking, we do the rapid assessment because it's just much more efficient.
Okay, and you say you get immediate feedback. What does that mean?
Well, after I've done the recording, then I sit down, do some calculations, and I go over the patterns associated with various conditions, and I query the client. I see in this record that you have a predisposition to depressed mood states. Are you depressed? I see in this that you've got a pattern associated with problems with planning, organizing, sequencing, and following through on things. Is that you? Etc. And people are startled by this. In fact, there's a chapter in a book written by Susan Olding. The book is called Pathologies, published by Freehand Press, in which she has a whole chapter on my intake assessment with her daughter. And she says exactly that I didn't look at any intake information, I didn't look at any of the records, and I was able to tell her more accurately than any professional she'd ever been to what the symptoms were associated with her child. Now, that's not me. That's the method that's doing that.
Tell us a little bit more about the method in plain English.
Well, after spending 30 years doing this, you kind of get the hang of it. And what we found, or what I found, was that there are very specific areas associated with most of the conditions that people complain about. 5 areas in particular. We look at the back of the brain, we look at the top of the head, and we look at the executive portion of the brain, 3 sites across the front part of the brain. And I have databases of 1,000 or so of my clinical patients, in which we can identify very specific patterns. So the trauma marker is a good example of that. You know, after doing hundreds of these things, then I identify what the trauma looks like, and I can say to an individual, you've got a trauma marker. Have you been exposed to a severe emotional stressor? What usually happens then is the person breaks down and starts to cry. You know, how'd you know that? And they're expecting to come in and spend a couple of sessions telling their tale of woe about what they've been through. And, 10 minutes into the session, I'm telling them what they've experienced. Now, that's like cognitive behavior therapy, because it's changing their entire understanding of what their disorder is all about, because I'm wording it in neurological terms for them.
So
that has a huge effect on people, absolutely huge, as you can imagine.
How? Tell me more about that.
I'm sorry?
How does it have an effect on them?
How?
Yes.
Well, okay, an individual has been through a number of physicians, and, they say it's all in your head. They send them to a psychiatrist. They talk to psychologists, and they're talking about the conditions under which they're not able to, let's say an artist staring at a blank canvas for a year. Okay, they come in and they sit down, I do the assessment, and I say to them, you've got a marker for exposure to severe emotional stress, and you have a predisposition to depressed mood states. However, I notice you have an artist signature. And are you a traumatized artist?
Wow.
And are you having problems with your creativity? Now,
you can see all of that.
You bet.
That's incredible.
And it's just, I have another book for for professionals. It's called the Basic Neurotherapy: The Clinician's Guide, and that describes this process in detail. And the Biofeedback Foundation of Europe has courses. We have 4 courses going now. At various levels, beginner, intermediate, and so forth, teaching people around the world how to do this. And a lot of the folks that were at your conferences know how to do it because we did a lot of workshops there, as you remember.
Oh, sure. For 15 years, my listeners, I ran a conference called Winter Brain Meeting, which I stopped doing in 2007. Paul, we're coming up on the end of the radio live session of this. This is the Rob Kall Future Health Radio Show, WNJC 1360 AM. And I've been speaking with Dr. Paul Swingle, a former lecturer from Harvard Medical School and professor at Ottawa University, who's now in private practice in Vancouver, with a practice that sees about 1,000 visits a month, which is an extremely unusual high level of people for this kind of work. Anything you want to finish up with for the listeners?
Yeah, basically that, if they address the cause of the problem and correct it with neurotherapy, that they can avoid all of the necessary issues associated with trying to sedate and medicate these problems. And it's a very hopeful procedure, and it's a self-regulatory procedure. That, I think, is the most interesting thing. What we were taught in medical and graduate school when I went to school is just wrong.
So what you're saying is very often the people you're working with can either stop taking medications or avoid ever having to take them.
Most of my clients come off the meds or, don't have to go on meds at all. Now, I don't want to give the impression that there's a knee-jerk reaction here. There is a very, very definitive place for medication. If somebody's ready to jump off a bridge, I'll medicate if you don't mind. But it's to get a person from place A to place B, and then you set the self-regulatory process in place and get the person sorted out.
Okay. All right, Paul, thank you so much. We're going to take a moment and switch over to the podcast side of this interview now. For the radio listeners, I'll be right back in a moment with Dr. Patricia Norris, former president of the Biofeedback Society of America, who is now a professor, associate professor at the Holos Institute, teaching intentional self-transformation, perspectives in transpersonal psychology. So we'll be back with her in a moment. And Paul, now we're going to continue this conversation more on a side at a level for clinicians and practitioners.
Mm-hmm.
So I'm not going to ask you to explain the big words anymore.
Okay.
And anybody can listen to it, of course, but the rules change here a little bit. So let's revisit we started off talking about brain driver working with autistics.
Yes.
Can you go into a little more detail about the underlying models and theories that you base your brain driver work on?
Yeah, sure. Basically neurofeedback is operant conditioning. Brain driving is classical conditioning. So operant conditioning, if something happens, the person gets a reward. So if a child, for example, who has a common form of ADD, where there's elevated theta activity, 3 to 7 cycles a second, elevated theta activity over the top of the head, for example. And what we want to do with this kid is just decrease that excessive theta amplitude. That's the only thing we're trying to do. Now, the way we traditionally do this with biofeedback is we set it up so that when the brain is moving in the direction that we want, namely reducing the amplitude of theta, then the icons move on the computer monitor. So it's set up, and all of the manufacturers have all kinds of fancy games and so forth. So the kid can play an exciting game, provided the brain continues to move in the right direction. Okay. Now, classical conditioning is a little different, and that is if that theta amplitude crosses a training threshold, a specific threshold, then lights kick on. And these are lights that are on the periphery of glasses, so the kid can look through them. They're open glass frames with lights around them. So the lights will kick on at, say, 18 cycles a second, and that will drive theta down. And when the theta gets below the training threshold, the lights go off. So it's a classical conditioning model. Now the brain driving procedure can use a lot of different stimuli. So we have sounds. My omniharmonic, for example, will suppress excessive theta amplitude. And, we have CDs that people can take home to use. But in the brain driving preparation, if theta goes above threshold, the harmonic kicks on as well. Now, for adults, we add microamperage stimulation EMF fields. So, for example, an acupuncture point.
Whoa! That is it. Tell us a little bit more about that. Microamperage EMF fields stimulations.
That's correct.
What is?
So, let's just say electrical stimulation of acupuncture points.
Using something like CES?
I'm sorry, what?
Using something like CES or cerebral electrical stimulation?
Well, you can use those stimulators, but you can't use that on the head because it messes up the EEG. Okay, now I presented the inaugural paper on the use of electrical stimulation on a pericardium point at your conference. And that was pericardium 6, which is a spot on the wrist, about three finger widths up from the crease in the wrist on the medial side. And if you stimulate that with electrical stimulation, it increases theta amplitude. Now, where I discovered all of these points is when I studied acupuncture over in Shanghai. They have a lot of points that they use for what they call mental problems. And what I did was I just brain mapped them all, stimulate it, and see what happens to the EEG. So we've got them that will decrease theta, increase theta, and do all sorts of things. So, but all of this is now classical conditioning. If the brain does something, then there's a contingency. And the contingency is something that will suppress a waveform or enhance a waveform. So in my book, Basic Neurotherapy, we talk about the various preparations. And it's not a very elegant title, but I call it push-grab. And that is, if you're trying to increase theta amplitude, for example, then when it falls below threshold, we can turn on a device that will increase theta amplitude. When it gets above threshold, we'll kick on something that'll hold it there.
And both of these are classical conditioning drivers.
That's correct.
Okay.
And now, I developed a standalone unit called the Brain Driver. And all it is an acoustic gate, so that when you set up your EEG to give sound output, for threshold crossings, it gives a sound. That's a usual feedback sound. Instead of the client hearing it, you route it to the Brain Driver, and that sound will trigger the relay.
Now, how is this different than more conventional sound light mind machines?
They're not contingent on anything.
So this is...
That's a static procedure. We know that if you flash a light at 10 hertz, for example, you'll get an increase in the amplitude of 10 hertz activity in the brain. And that's the entrainment model.
Okay,
but that's not contingent. It's not contingent on what the brain is doing.
So the difference is the Brain Driver is activated based on changes in the behavior of in the activity of the brain.
Bingo.
And so why is that better?
Well, do you think Pavlov's dog would salivate if you didn't ring a bell? I didn't give food when you rang a bell?
Go ahead.
Am I being too obscure? You can ring it.
I'm trying to get you to spell it out, not be.
You can take a dog and ring a bell forever, and they're not going to salivate. But if you ring a bell and give them a little food, a little meat powder, every time you ring the bell, then take the, then test and ring the bell without the food powder, you find that the dog salivates, a la Pavlov.
But wait, but we just discussed that the mind machines do produce some response by just turning them on, and so it's not quite the same.
Yeah, I'm not saying I'm not criticizing the standalone harmonics and standalone AVS machines. I think they can be very useful. All I'm saying is it's different. Now, I use the AVS machine, but I make it contingent. That I use the AVS machine going through my brain driver, and it'll only turn on under certain conditions. So I turn it into a classical conditioning model.
So you use commercial AVS machines, mind machines?
Yeah, sure.
Which brands do you use?
I use them all. I have them all. As I've said to you many times, I have all the toys.
Yes, you do. Okay. Now, I want to get back to something,
sure.
Let me let you finish this up. Have you wrapped up just describing this process in your model here?
Yeah, I think, folks that work in this area will be well aware of the advantage that classical conditioning can have, because you can deal with people in coma, you can deal with serious brain injury, you can deal with serious autistic kids. They don't have to be attentive. You're using classical conditioning. And when the brain gets in decent shape, then you can transition over into regular biofeedback. That's the nice thing about this. You can combine them so that you can have brain driving over regular neurofeedback and then gradually titrate out the brain driving.
Okay. Now, have you worked with coma?
I'm sorry, have I worked?
With coma patients.
Coma? Oh, yeah.
Yeah?
Sure. Coma and serious brain injury and epilepsy. We've been doing a lot of work with very rare and terminal forms of epilepsy like West syndrome using brain driving. And we've had some success.
Okay.
These are kids 4 and 5 months of age now.
Where, of course, you couldn't use neurofeedback, which requires giving explanation of how it works and what to do.
Bingo. That's where the brain driver comes in.
Right. Of course, with the coma patient, that would also be the case.
Mm-hmm.
You know, I had an extensive conversation on last week's show with Jay Gunkelman about his work with coma. Apparently, there's a decent amount of money for funding for that if you can identify the markers in coma and develop things that work to bring people out. Are you, by the way, doing anything with veterans with the military PTSD?
No. We see veterans with PTSD, but we're not doing anything official with the Canadian version of VA. And we've been in touch with some of the chief honchos, and very peculiar, you know. It's very politicized, I'm afraid.
Well, what I hear...
I understand Siegfried is trying to do some work with, those folks down in the States.
Yeah, Siegfried is, but Jake Unkelman is having some good success. He says the word is you don't use the term neurofeedback or biofeedback. You use brain interface.
Aha.
You may want to listen to last
That would make sense, yeah.
Yeah, he went into that in great detail. Now, I want to cover one other thing with you. Now, you talked about, and I remember now, you spent a lot of time learning acupuncture in China.
Right.
And now you're saying that you tested different acupuncture points' effects on brain activity patterns?
That's correct.
I've never heard anything about this before. This is fascinating.
Well, you should have come to my workshops at your conference.
Well, I was busy running 5 other workshops and keeping the thing going, so I apologize for not being there. So you did present them at my conferences, and you're saying that your presentations would be on the DVDs and CDs that we have from those presentations? I
guess, yeah.
Okay, so but talk a little bit about it now, and what you know from that. What has that taught you about the brain, about acupuncture, about neurotherapy?
Well, and what startled me about when I went to the institute in Shanghai to study acupuncture was we used point finders, the electronic point finders. And these are devices that move along, you move along the presumed channel, and when you get to an acupuncture point, it'll beep. And what it's looking at, it changes in impedance. What we found was that the sites that were identified electronically are exactly the sites that they've been talking about for thousands of years. Now, how the heck did they find those? So, what I concluded was that this isn't all smoke and mirrors, that there's a lot to these energy systems that are running through the body. So with that mental set, I set off to brain map, look at the EEG effects of stimulation at various points on the body. Now, one of the things you can't do, unfortunately, with the EEG is you can't have continuous electrical stimulation around the head and measure the EEG. It goes crazy, obviously.
Right. So
we were looking at the peripheral sites, and we found a couple that are dynamite in terms of impact on brain activity. So we have preparations, again described in my book, Basic Neurotherapy, for emergency treatments for people who are in severe states of depression and anxiety, panic. And what that, one of the parts of that protocol is the stimulation of pericardium 6. That was the site I was just telling you about. And it's contingent on brain activity. So we stimulate the acupuncture point. We stimulate with lights, the lights that I was describing before, using Brain Driver again. And we use my sweep harmonic. Now, my sweep harmonic is a sound that moves from side to side, and it balances the frontal cortex. Ray Tattenbaum.
When you say side to side, you mean from one side of one ear to the other ear, so it affects one side of the brain, then the other side of the brain? Okay.
That's correct. It's kind of like an EMDR protocol. And I've gotten some extremely good feedback from clinicians on it. People that have used EMDR, like Lee Poulos, for example. He uses my sweep now instead of the EMDR protocols. And Ray Tattenbaum, who you know,
sure,
has had some very, very good effects using the sweep harmonics. You wrote me a very
now
nice
Ray works a lot with peak performance as well.
That's
we haven't
right.
talked about that, but I'm sure you are working with that as well.
Absolutely, yeah.
You have any Olympians going to be showing up that you've worked with?
Just watch the guys on the podium. They have an unfair advantage.
Okay, that biofeedback is getting to play a bigger and bigger picture. With this new mind room that Thought Technology and the Milan team is developing. It looks like it's going to be a big thing.
Yeah, there are a couple of teams, Canadian teams, hockey teams, for example, that are setting this up. And it's just going to be part of, well, that makes sense, of course. It's just part of the training.
Absolutely.
And I see a lot of CEOs of pretty large companies, and you can get very, very precise in terms of, brain configurations that these people find optimal. For example, the anterior cingulate gyrus, that's an area associated with willfulness, stubbornness, passivity, and, it's the OCD site. What we do is we keep it a little hot with executives, and that gives them that edge. That's why they're on the top of the pile.
So when you're working with an executive, you described how when you're working with somebody with trauma, you can look at a profile with your quick cue or your brain map and get an idea of their problems.
Yeah.
How do you handle it differently when you're doing peak performance work and working with an executive?
Well, the first thing, an executive will come in and, I want to do optimal performance. The first thing I tell them is the first thing we do is balance everything. If you have a predisposition to depression or if you have a sleep quality problem, et cetera, and I do a quick cue on them and I go over it with them and make sure that what the brain is telling me is consistent with what they will admit to. And generally speaking, we're right on the money. It's rare that we're not. So, we do a few, and by the way, talk about gaining confidence in somebody when they sit down and you don't know a thing about them, and you tell them all of this kind of stuff.
What kind of stuff? That's what
confidence levels go through the roof.
Give me some examples. What kind of stuff do you tell them that gives them confidence through the roof?
Okay. There's an elevation of beta amplitude in the back of the brain. Clients often report that they have problems finding the switch to turn their brain off, problems finding peace in your own head, a lot of chatter, poor sleep quality, predisposition to anxiety, often self-medicating behavior, and often fatigue. Okay? That all comes from one measurement in the back of the brain. Another one, marked elevation of alpha amplitude. Do you have any artistic skill or interest? Are you good at mathematics? Do you like to build things? Are you artistically inclined? And clients who haven't said boo to you about that, their eyes, particularly parents, when you say that about a child who's, really into making things, the parents' eyes just open up like full moons. How'd you know that? Center of the brain, and everything's honky-dory until you started to read. Do you find that reading is tiring? Do you have a situation in which you read, you get to the end of a paragraph, can't remember what you've read? Okay? You can tell all kinds of things from the brain because there are patterns associated with these sorts of things. As I say to clients, the brain tells me everything. Now, you've done that with an executive, and then the first order of business is you take care of any of those departures from normative functioning, and then you get into optimal performance. And the first order of business in optimal performance is increase the peak frequency of alpha. Correlates with IQ and good immune functioning. Second is you make sure that the frontal cortex is nicely balanced. Third, you find out where they want to be in terms of how many balls they want to keep in the air. So although the ideal theta-beta ratio in the back of the brain might be 1.8, they might feel better at 1.6. That's where I keep myself, 1.6.
What is that? What's the difference between 1.6 and 1.8 theta-beta ratio?
You and me.
How dare you?
I couldn't resist. I couldn't
your
resist.
smart-ass remark. Yeah, I know. Look. You're a pushy New Yorker from Brooklyn. You can't help it. I realize that. I love you for it. But what is it really? The difference between 1.6 and 1.8.
1.6, you're in a movie, you're watching the movie, you're solving a couple of other issues in the back of your head. You're keeping more on the go at all times.
Or juggling of things in
That's
your head
correct.
too.
Yeah, exactly.
Right, so 1.6 means a bit more theta then?
No, 1.6 means a little more beta in the back.
Or beta. Oh.
Yeah, or lower theta. Now, I'm a real alpha junkie, so I like to keep my alpha really fast. And when you get to be my age, you have to pay attention to that because that's an age-related decline, or can be. So folks my age come in 3-4 times a year to keep the alpha fast to prevent Alzheimer's dementias.
What would you say is fast compared to slow?
Well, I use an alpha density model as opposed to peak frequency, but they're correlated. And in the software we have with BFE, it gives you both peak frequency and alpha density.
You're not answering the question, though. You're saying you want alpha fast. Does that mean it goes to 10.5 hertz up from 9 hertz? Or
That's correct. That's exactly right. So you want it over 10.
All right, and basically with aging, alpha, it tends to drop.
That's correct.
Slow down as
That's right.
The peak alpha frequency. Okay. All right, Paul. I think we've reached a point where your 1.6 over my 1.8 has me tired, and no. We've reached a good point, I think, to wrap this interview with the Rob Kall Future Health Radio.